So firstly, I'd like to also join my sort of own acknowledgement of country. As Peter's introduced me, I worked for a long time in the Northern Territory. So I have a lot of gratitude for the Aboriginal elders and young women who taught me many things and many things about health that I never thought I would understand. So I thank them. And today we're coming from Lutruwita, Tasmania, and it's a very warm day, which is great for us here. One of the things that I have great pleasure in, it's the right time of year, is to coordinate the public health courses, which the best thing about coordinating the public health courses is not only just teaching, but watching people graduate. And I think graduations are always great fun to celebrate after all the trials and tribulations of studying. It's something we share together. And the key things about public health that we really try to get across is a number of competencies. The main thing we do in public health is learning how to analyse and address the determinants of health. So it doesn't matter which unit you might take within a public health suite, you'll always be looking at analysing and addressing the determinants of health. But you'll also be looking at what actions you take about proposing, plan, implementing, and evaluating culturally appropriate evidence-based policies and interventions. It's the second part of that that I'm going to spend my time on today. So before I go anywhere, I think most people's understanding of public health has been influenced by COVID. And it's something that we've shared as a world together, and many countries have tackled COVID differently. And when I begin talking about public health interventions, I think one of the ways of saying there are many ways to approach public health interventions is to think about how different countries and the different things that were done in different countries to tackle the COVID-19. In saying that, the one thing that has really come up is that the need for a strong public health workforce. And it is something that many countries fell short with, is that they did not have enough people trained in public health skills. And also that people working in other areas of health also needed to understand basic public health knowledge. So whether you're entering public health as your main game, or whether you're just thinking of doing a unit within the advanced practice suite that might be a public health unit, these are all contributing to a better health workforce overall. So just to set the scene, there's a number of public health functions that are key. And if we think about the whole idea, I mentioned public health surveillance and analysing and data and monitoring, that undercuts everything. But there's a number of public health functions around public health emergency management. We've seen that in COVID come into place. You saw legislation that you didn't know existed enacted, and things like Australia pulled up their borders, and different countries use their emergency management legislation. We also see that when there's cyclones, bushfires, and other types of emergencies. So 3 core functions are really around health protection, disease prevention, and health promotion. I'm not going to go into these because public health is a really broad area, and you'll start to see that. But we've got lots of systems, inputs, and enabling things. The way we manage the leadership, our planning, our financing of public health, the community engagement, workforce development, which is sort of where I probably sit in that, in sitting within a university, very much around building a public health workforce, or a health workforce that has a really strong public health understanding. We've also got a real focus on quality of the health services and very much health equity, and I'll talk about that later. There's also public health research and knowledge, which as an academic we participate in, and the access and utilisation of equipment and technologies. So you can see public health people getting very involved in digital health as well, for example. So unpacking that a little bit further, I've got up a diagram there with the World Public Health Associations, the idea of pulling those into a diagram, the protection, prevention, promotion, and building that capacity, governing, providing information and advocacy. It starts to build this picture. So any public health course or a Masters of Public Health is going to cover these main things. Public health intelligence, again, that's that information, the data. If I'm to use the COVID-19 example, you would have seen real-time data every day presented, local data, national data. We were very much acting on the information that's provided. But we do that for many things, many disease patterns as well. And we don't always have live real-time data. So this all builds to the public health evidence. A lot of the things need to be examined more closely to build that evidence base. We try to provide evidence-based activities and base our actions on evidence. So a lot of what I'm talking about today will be about designing and implementing interventions that have been developed and have some evidence behind that they will work. So not going completely through that list, what I want to really focus on is that design, implement, evaluate, engage, and collaborate. And the whole purpose is to build resilient health systems, improve the health of populations, and advance health equity. Lots of buzzwords, lots of big words, but hopefully through the example, you'll start to see the whole nutshell of what public health is about. You will have already noticed that if you come from a clinical background, I have shifted from talking about individuals, clients, patients, to populations, groups of people, communities. So we lift the public health really is about large groups of people or particular types of people within a population. That's our focus. So I can think about, what are public health interventions? I really wanted to just touch on this because sometimes we forget that public health interventions have happened and been very successful around us. We can get lost in that. And the Public Health Association a few years back put out a document around the top public health successes in Australia over the last 20 years. And even though I've been a public health practitioner and you're always looking, I guess, for new things, when you reflect back on this, what were the public health interventions that really counted? And they listed things like the introduction of folate, so that reducing neural tube defects. So providing mothers with adequate folate was one of these interventions. And what they did in 2009 was introduce mandatory fortification of folate in bread, so that it was a population-wide fortification of the bread, and so mothers would have enough folate in their diets to prevent neural tube defects. And the improvements, or the less children born with neural tube defects, followed that intervention. We then got basic immunisations, things like measles, mumps, rubella vaccinations. We've got meningococcal vaccinations. We have rotavirus vaccinations, and I can talk personally about the development of the rotavirus vaccinations. If you're unaware of rotavirus, it caused diarrhoea diseases. And in the Aboriginal communities back in the 2000s, children living in babies living in remote communities contracting rotavirus. And I can even say personally, my own daughter contracted rotavirus, and it's a severe diarrheal disease and can require hospitalisation for treatment. So these vaccinations were really groundbreaking interventions for some groups of the population. We've also had things like eliminating cervical cancer through national screening programs, and then the HPV vaccines that have come into play. We've had oral health and water fluoridation the water fluoridation that's really improved our oral health. And that's still to be extended to all communities. There's places in Australia that don't have fluoridated water, and there are some controversies around it, but overall the impact has been great. There's also the skin cancer prevention. Who can forget the slip, slop, slap sort of health promotion campaigns, and increasingly people wearing, hats and sort of using sort of preventive activities, not going out in the sun in the middle of the day and things. That's become part of our life. So those health promotion campaigns have been very strong and repeated and quite successful. Probably one of the more successful, not more successful, but well-known Australian interventions that is envious by other countries is our introduction of plain cigarette packaging in 2012, when our then Health Minister, Nicola Roxon, made the decision to introduce plain cigarette packaging. And its impact on reducing tobacco smoking has been really strong. And we sort of led the world there on tobacco interventions. But also we've had road safety programs, we've had national gun control, and of course it's very personal, the national gun control, speaking from Tasmania, because that was in response in 1996 to the Port Arthur massacre. But we've also introduced HIV treatments and treatment through making the treatments available free through the pharmaceutical benefits scheme in Australia. So these are sort of, if you're thinking about what are public health interventions, these are both policies that influence change at a population level and to try to improve the health of the whole population. So I often go to something when I'm trying to think about how to explain how you would put a intervention in place and how well you need to design this intervention and carry it out. This photo always reminds me of being in Northeast Arnhem Land at one of the initial Garma festivals, where this van had been built to be able to provide dialysis on land, so that some people will be able to go to this festival to participate in some cultural activities, but they needed to be dialysed. They had renal disease. And they built this van. It came in across the track. I drove behind it. It had a lot of trouble crossing the track, but it was built to be on a four-wheel drive basis. But when it got to the grounds that it was going to be doing the dialysing on, one of the issues that became apparent is that it needed quite a lot of water to dialyse, and the level of water was not available at the level. It did dialyse some people, but it was one of those things, and the journey through the very rough road had disrupted a number of things in the van. So sometimes it's all about context, is what I'm trying to get to here, and a well-designed intervention needs to take into place the context. Even though the van had on board some greatly skilled nurses around being dialysed and had all the equipment, some of the basic stuff was being able to get across the road and have enough water to run the van. So nevertheless, it stands as an achievement of trying to take care closer to home, which was a policy initiative at the time, was to try to reduce the impact on people's social and cultural lives of having renal disease. So just to stay on the theme of renal disease, I picked up a couple of things to really reiterate why population health sometimes focuses on disease at population level rather than an individual level. Taking the Aboriginal and Torres Strait Islander population and looking at the statistics that are reported around kidney disease, and this is off the Australian Institute of Health and Welfare database. You can see here in the blue are the numbers of, or the age groups of the Indigenous Australians compared to the non-Indigenous Australians. And you can see at every age, Indigenous Australians have more self-reported kidney disease. And on the right there, you can see that it doesn't matter whether it's male or females, it's a higher rate. And for those of you who may be tuning in, sort of wanting to understand, no state is out of this picture, particularly, you know, the high rates in Western Australia and Northern Territory in the remote areas for kidney disease are there, and the remoteness is a big factor in kidney disease. So this type of large data sets are part of the public health gathering the picture, understanding the information. But health equity comes down to it. So here I have a article. I've drawn this from an article by Dr. Jackie, or Professor Jackie Hughes, who's an Indigenous Australian who is a renal physician and who also does public health research. So what she's really saying here is that even though there's a smaller number of Indigenous people than non-Indigenous receiving kidney replacement therapy, that 85% of the Indigenous patients were on dialysis, and a smaller number had a functioning kidney transplant. But so many more of the non-Indigenous patients were on dialysis. Sorry, so many more of the non-Indigenous patients had a kidney transplant. So the equity around receiving a kidney transplant is a real issue for Indigenous Australians. So that's how you that's how we use data to try to understand where's the health equity and how do we improve equity. There's many reasons behind it, and that is where public health will often try to work, is to reduce the inequities between different groups of people. So one of the main areas I wanted to then talk about today, I'm just checking my time, and that is around use of theories to design interventions, to implement interventions, or to evaluate interventions. We often don't talk about theories very often in our everyday world, but the idea that we have a abstract or that we can predict situations is really what theoretical understanding gets to. So we want to be able to design interventions that are more likely to be effective. So we use theory here to be able to predict or be able to understand why people do or do not practice health promoting behaviours, for example. So one of the early, I guess, theories is the health belief model. And I think you'll recognise this. It's just that people's beliefs influence their readiness to take action. If they believe or perceive that they're susceptible to risk, or that they have a good self-understanding on, they're more likely to engage. For example, in cancer screening, if you think you're at risk, people will engage in it. And often this happens in the bowel cancer screening patterns, is that people are reluctant to undertake bowel cancer screening. And for those of you who've turned 50, I think it's one of the surprises that you get in the mail is a bowel cancer screening kit. And for many people, they don't believe they're at risk of bowel cancer. So they often don't. They are reluctant to take part. And that's one of the areas that they're doing quite a bit of research in. So how do you influence people to say you can also be at risk? And then there's things like the stages of change. So people's the sequence of behaviour. People contemplate changing. You might recognise the need first, then you might contemplate changing. You might start preparing or planning to change, and you might begin to adopt new habits. And you might think about how the quit line introduces smoking, and initially we start to sort of say, have you thought about not smoking? And you start to prepare people, and then you support them through maintenance. So that's the idea of the stages of change. The socio-ecological model, I've got a little picture up on the side here. So that's really that understanding that there are many influences around an individual. It's not just an individual, it's at interpersonal level, it's a community level, organisational level. And often we need policies that enable the environment to make it easier for us. We were pretty responsive when we changed the, I think an example there is the policy environment around smoking. When that sort of changed and it became unfashionable, it was much easier to support non-smoking if that was your choice. I've got IPARIS and RE-AIM, and in the next slides, I'll go into those models a little bit more. So I just wanted to, these are different things I know for people, and they're not really about getting over them. It's just really advocating for these can be informative. And so in designing, public health interventions, you might have something like this health belief model that's I've just been speaking about, to design people that they might be able to believe that they can take all their TB drugs. So I've just put up some papers that are easy to find in the library around where people have designed interventions to do particular things by using these health belief models. So if this particular paper is around TB treatment, if you know much about tuberculosis treatment, you know that you need to get people to adhere to long-term medication, usually over 6 months. And this was an Indonesian study that really wanted to control their problem with TB and get people to take this long-term medication. And so they trained community workers with trying to introduce and get people to understand why they would need to continue to take their medication. So they really undertook motivational interviewing and around the health belief, using the health belief model. And the assumption was that if individuals perceived that they were vulnerable or susceptible to the disease, that they viewed the disease as severe rather than as a mild disease that was okay for a long time, you start to convince people that the prevention regime is actually effective, it has benefits. So this is something where you sort of use a health belief model to introduce motivational interviewing. And you've also got another one there around using the social ecological model for infant bed sharing. This was a United States piece of research where on the next slide, they laid out all the ideas using a social ecological model, all the factors that impacted on whether a mother or father, for that matter, had the child sleeping in the same bed as them. And without going into this study, what you can see is that at every level of this socio-ecological model, there was a piece of information that would need addressing in any intervention that was going to take place. You can't simply tell mothers and fathers to not have the child sleeping with them, which is associated with a higher risk of death. So they needed to unpack this whole, understand at every level what it was impacting on people's behaviours. So these are about changing people's behaviours and using a theoretical model to understand why people were behaving in that way. And here's another framework, one that I use actually, that might be used for implementing interventions. The promoting action on research implementation in health services, you might have heard of it, the Paris framework on the left there. It goes along using the evidence, the strength of the evidence, the context in which you're applying it, and the use of facilitation to enable the evidence to be implemented in a context. And I put this slide in here around the Paris framework because this is, you'll see the original Paris model was designed in 2004, and we've got in 2016 an Paris framework where they expanded on the original ideas, the original theory. And so now you have an expansion. So theories don't stay the same. They get expanded on the more people work on them. And here, they really expanded on, there's not just a local context, that was an organisational context, and there's an outer context. So if you were to take change in a hospital, for example, you'd have your local ward, your whole of organisation, and the outer context might be the policy context in the national government, or something like COVID happening in the community. So you have to take context into accordance and in designing or implementing interventions. So the idea of this is that successful implementation is more likely to occur when you've got good evidence that is believed by the practitioner and has some relevance to your local experience. And so these are the idea that it makes sense to you, more likely to take a new idea and put it in place if it makes sense to you and you have some idea that it could work here. And that the context you have might be pretty sympathetic to that idea, that it might need something to change, the understanding that you might have really good leadership that says, we'll put this in place, and that you might have a great facilitator to help you work through all the changes that need to happen. And I know that this is quite close to that Peter also uses this in healthcare redesign. It's this idea that these theories are not just used in public health, these are used more broadly. And so I'm just sort of putting it out there that these are things that you could take note of. And there's a number of examples where this has been used. And I'm not going to go into those, I'm just putting them out there that people have been using these to implement different types of studies in different types of places. One in there is the chronic care model and trying to implement these things. And theories can also help us in evaluating interventions. And this is getting down to what I guess I really focus on as evaluation. And one of the theories here is what's called the re-aim framework. And I have it on the left there. It's really about the reach. How do I reach those who need this intervention? One of the things that we often find is that a program can be put in place, a policy or a program, such as I'm going to, a maternal and child health program that's designed to support young mothers, perhaps. But how do you reach those people who are young mothers? How do you reach those with diverse backgrounds? I think we all can think of examples where interventions have been put in place and that are great interventions, maybe a childcare group or an educational program, but those who most need it are really hard to reach. They're really hard to connect with. Also, that you look at the effectiveness. How do you know that your intervention's working? Who adopted it, the adoption of it? How does the organisation support people to deliver a program? And how do I ensure that the intervention's delivered properly? This is particularly relevant when you have an intervention that's delivered at many sites. And an example that comes to mind is some of the COVID work that was happening at different sites around feedback of results. And how do you make sure that that happens the same at every place? And then what we have had to do is maintenance. How do you incorporate an intervention that appears that is working, it's evaluated well, but how do you put it into place over a long term? And again, you think about COVID. How do we incorporate what we learnt during COVID into our everyday long-term work? It's been really hard. It's hard to keep up the hand washing. That was always a good idea. It's hard to keep up some of those preventive practices that should be part of it. And here you can see, I've just put a couple of examples around where different types of interventions have been evaluated using a model to help guide the intervention, the evaluation, so that you understand very much around the evaluation. Was it the implementation that fell over? Did people not have enough resources? Or it's really, we got it in place when we had all these extra staff, but now we can't maintain it because we can't have all those extra staff. It's a really classic one, is that you put a special intervention in, particularly when researchers are to blame here. Sometimes we get grants, we get staff, we get extra running, extra resources. We can get it in place, we can show that it works, but maintaining it in everyday business is can be difficult. I just wanted to end there, really, in that I just want to make the case for thinking and working at a population level, and public health is the discipline that does that. So I was going to hand back over to you, Peter, and anyone who's got any questions. So I'm happy to stop sharing now.